afternoon, everyone. So having heard about the medical management of hyperparathyroidism in CKD, there are certain cohort of patients of chronic kidney disease who don't respond to medical therapy. So here comes the role of parathyroidectomy. So I'm going to discuss about various indications for parathyroidectomy and what are the challenges we face during the process. So as we all know, secondary hyperparathyroidism is a disorder of phosphocalcemic metabolism. The triggers being hypocalcemia, decreased vitamin D, and hyperphosphatemia. This is important to know because as the PTH secreting glands increase, it causes parathyroid hyperplasia. Initially, there is a diffuse hyperplasia causing localized increase in the number of cells secreting parathyroid, but then it progresses to nodular increase, which ultimately forms a single nodular gland. It is important to note that as the gland forms nodules, the vitamin D receptors and calcium sensing receptors and FGF receptors decrease in number, making our conventional treatment with calcium mimetics and vitamin D analogs ineffective. So here comes the role of our parathyroidectomy. So there are certain indications which I would be dealing in coming slides. So before that, these indications along with the laboratory abnormalities mandate parathyroidectomy. So the skeletal manifestations like high turnover bone disease as described previously, osteitis cystica fibrosa, which is manifested by the formation of woven bone due to increased osteoblast and osteoclast formation, increase in the osteoblast and osteoclast. It causes peritrabecular fibrosis. And non-skeletal manifestations, out of which calcemic uremic arteriopathy is one of the dreaded complication of hyperparathyroidism, which is characterized by extensive calcification of intima of medium and small vessel arteries of the peripheries, characterized by gangrene in extreme cases. The other cardiovascular manifestations like presence of coronary artery calcification, which affects the media of the arteries, contrary to the atherosclerotic plaques, which affects the intima. And the metabolic manifestations like abnormal lipid metabolism, insulin resistance, and glucose intolerance can occur secondary to hyperparathyroidism. And the miscellaneous complications which mandates parathyroidectomy include pruritus and anemia. Anemia in hyperparathyroidism is secondary to the marrow fibrosis, and also PTH causes decreased lifespan of the RBCs, affecting erythropoiesis. So these are certain indications which are in existence from 2001 to 2020. So I would be going one by one. So in 2001, evaluation of renal transplantation guidelines say that calcium, phosphorus, and PTH to be measured as a part of pre-transplant evaluation and should be periodically monitored while patients are on transplant waiting list, that is every quarterly. And it also says that parathyroidectomy should be considered for renal transplant candidates who have failed the medical management or have severe life-threatening complications secondary to hyperparathyroidism, as we know. Then in 2005, we have Canadian Society of Transplantation guidelines, which also reiterates the same and also says that parathyroidectomy should be considered medical management has not worked. And in 2015, we have European Renal Best Practice Guidelines, which recommends that efforts should be made to comply to the CKD MBD guidelines. The ranges should be should be maintained within the guidelines which are there. So, but anyway, but however, they don't refuse a cadaveric graft only because of hyperparathyroidism. In 2020, KDIGO guidelines also reiterates that you have to measure serum PTH at the time of pre-transplant evaluation and also periodically. And also it suggests that don't transplant candidates with severe hyperparathyroidism until they adequately treated and meet the guidelines as prescribed by CKD MBD guidelines. So because hyperparathyroidism, persistent hyperparathyroidism post-renal transplant is an independent risk factor for allograft dysfunction. So this Japanese Society for Dialysis Therapy in 2006 has given some elaborate guidelines, the absolute indications being persisted elevated levels of intact PTH more than 500 picogram per ml or old PTH more than 300 picogram per ml with hyperphosphatemia more than 6 milligram per deciliter and hypercalcemia more than 10, which are refractory to the medical therapy, along with one of the 7 symptoms, that is clinical symptoms of bony pains, high turnover bone disease, progressive bone loss, progressive ectopic calcification, calciphylaxis, ESA resistant anemia, or dilated cardiomyopathy like cardiac involvement. And other strongly recommended conditions are that presence of lab abnormalities without the presence of any of the symptoms, it is recommended. And the other recommendations being the intact PTH levels below 500 but more than 300 with hyperphosphatemia and hypercalcemia, along with enlarged parathyroid glands as detected by ultrasonography, in which estimated glandular volume is more than 500 millimeter cube, and the major axis diameter of the parathyroid gland more than 10 mm. So here it is strongly recommended even without any symptoms. So to summarize, these are the guidelines we have. So KDIGO recommends whenever there's a failure to achieve intact PTH levels within 2 to 9 times the upper normal limit, go for parathyroidectomy. KDOKI also suggests go for parathyroidectomy if you have persistent serum intact PTH levels more than 800 picogram per ml despite your medical therapy. And the JSDT guidelines 2012 also reiterates the same as I've discussed, along with the presence of clinical symptoms, clinical signs, and the imaging. So when do we time this parathyroidectomy? So it is important to know that calcium mimetics can prudently cause low calcium levels and mask tertiary hyperparathyroidism. So whenever we are testing PTH, it is suggested that you stop calcium mimetics at least for 2 weeks and then test for PTH. So a cutoff of PTH of 1000 picogram per ml without calcium mimetic use, or 500 picogram ml with calcium mimetics are indications of parathyroidectomy. So the timing, if the individual is listed for cadaver or live, as and when you optimize the therapy and they don't respond despite 6 months of optimal therapy, go ahead with parathyroidectomy. So what are the surgical concerns we have? So we need to do extensive preoperative imaging for parathyroid. Why? Because parathyroid is known to have supernumerary and ectopic parathyroid glands. So it is important to screen, to image, because it is essential to ensure complete removal of the glands, because they are a concern for recurrent or persistent secondary hyperparathyroidism. And the resurgery for parathyroidectomy also carries a risk of injury of recurrent laryngeal nerve. And the common sites for ectopic parathyroid glands are around the upper neck area, carotid sheath, within the thyroid gland, in the mediastinum, and in the thymus. So how do we do? So we have 3 or 4 modalities here. As we know, ultrasound, which is cost effective, non-invasive. CT is good in identifying main and ectopic parathyroid glands, although PT parathyroid glands in thymus and thyroid gland can rarely be missed. Technetium 99 Sestambis scintigraphy identifies ectopic PTGs, especially in the mediastinum and upper area. So what is the diagnostic accuracy of these tests? So is one imaging enough, or do we have to do a combined? So if you see this data, so the diagnostic accuracy is calculated for imaging of 4 normal PTGs. If you see here, individual imaging, that ultrasound carries an accuracy of 57 compared to CT, which is 60, compared to technetium, which carries 42%. And the combined accuracy is more, like combined ultrasound and CT is more, 73%, and combined ultrasound, CT, and technetium scan is in the range of 75%. And when you see the ectopic parathyroid gland imaging, the diagnostic accuracy decreases further. It is difficult to identify these glands. So it is recommended that sensitivity of the combined imaging is better. For the recurrent parathyroidectomy procedure, you can skip ultrasound, because it's more often the ectopic and supernumerary which are missed by ultrasound. So CT and technetium scan will suffice. And SPECT and CT, which is a fusion of CT and Sestambi scan, is the latest modality. The other surgical concerns we have are metabolic complications post-surgery, which I would be discussing, and vocal cord paralysis due to recurrent laryngeal nerve and hemorrhage. So the surgical procedures we have are, you have subtotal parathyroidectomy with transcervical thymectomy, total parathyroidectomy without transcervical thymectomy and autotransplantation, total parathyroidectomy with transcervical thymectomy and autotransplantation. This is what we commonly practice. Total parathyroidectomy with transcervical thymectomy and without autotransplantation. So in subtotal parathyroidectomy and transcervical thymectomy, we remove 3.5 glands and leave 40 to 80 milligrams of PTG tissue. So what tissue are we going to keep it? So PTGs with a normal appearance are favored for preservation to avoid recurrence. And transcervical thymectomy is usually added to avoid recurrent hyperparathyroidism due to ectopic or supernumerary PTGs in the thymus. So the advantage is that as we are leaving some amount of PTG, you have hypothyroidism can be avoided. But the disadvantage is that there is a risk of direct dissemination to the surroundings, and there might be increase in the parathyroid hyperplasia from the PTG stump. Coming to the total parathyroidectomy without transcervical thymectomy and autograft, it is performed to prevent hypoparathyroidism after parathyroidectomy, as PTH secretion is expected from ectopic and supernumerary PTG. So usually we don't do thymectomy. So this has an advantage of that hypoparathyroidism can be avoided, but the disadvantage is that there's a risk of recurrent persistent secondary hyperparathyroidism due to remnant PTGs in the thymus. This is what we commonly follow, total parathyroidectomy with transcervical thymectomy and autograft. The most common location for autograft is the forearm, because it is easy for removal in case there is a persistent hyperparathyroidism. It is favored in patients expecting long-term dialysis and those expecting kidney transplantation. So the advantages, hypoparathyroidism can be avoided, and then again we are not doing sorry. Yeah. Also. Yeah, it has an advantage that there is a minimal risk of persistent and recurrent secondary hyperparathyroidism because we are doing autograft here. And then the disadvantages, diagnosis of causative PTGs in persistent or recurrent, it is difficult to screen here. So I'll just, this is another procedure which we usually don't follow. So there is comparison of techniques. There are not much difference between the techniques here. So total parathyroidectomy is favored in patients who need long-term dialysis, although special attention is necessary for cardiovascular events because of hypocalcemia. And subtotal parathyroidectomy is indicated for patients with secondary hyperparathyroidism expecting kidney transplantation in the near future. So the concerns we have are the injury to the recurrent laryngeal nerve. So we have intraoperative nerve monitoring, intraoperative PTH monitoring, and frozen section diagnosis. So intraoperative nerve monitoring is done by electronic stimulation of the laryngeal nerve, which causes movements of the vocal cord detected by the attachment around the tracheal tube. So, but there are certain fallacies over here. False positives can happen due to delayed neuropraxia. That means the nerve is not injured, but there is no vocal cord movement. False negatives are seen where there is malpositioning of the tracheal tube, where intact vocal cord movement is identified despite a negative ION response. So, this is how it is done. So, you have electrodes which are attached to the endotracheal tube and you stimulate the nerve and see the response or the movement of the vocal cords. Coming to the intraoperative PTH monitoring, the most common PTH monitoring we use Miami criteria. So it ensures that calcium normalization persists beyond 6 months. So a pre-incision and a pre-excision PTH levels are sampled. A greater than 50% fall from either the highest pre-incision or pre-excision hormone level at 10 minutes. After all the glands are excreted, it denotes a successful operation. There are other criteria, but the most common we use is that. So, but again, there are some false positive and false negatives over here. False positives, yeah, I'll just... one important thing is site of IOPTH sampling, wherein it can be either central or peripheral. Central is from the IJV site, which is in close proximity to the operative site. The central values are slightly higher, but you can choose any site, but choose only one site. And frozen section diagnosis is important to know because sometimes thyroid glands, lymph nodes, and adipose tissue are misdiagnosed as surgeons by PTG. So we send a frozen section diagnosis. This ensures also the autograft is only parathyroid which is placed.
Sir, I'm afraid we are running short of the time for the oration.
Okay, ma'am, I'll just continue. So the post-parathyroidectomy care, patients with normocalcemic hyperparathyroidism who have persistently elevated PTH levels after parathyroidectomy should be evaluated, and we have to ensure normal calcium. If the patient is having normal calcium but despite high PTH, they should be followed up. So take-home messages are that patients with secondary hyperparathyroidism refractory to medical management, parathyroidectomy is the best treatment, and pre-operative imaging diagnosis and other intraoperative measures are critical. Post-operative complications should be closely monitored for recurrent laryngeal nerve injury and hungry bone syndrome, and they should be followed for recurrent and persistent hyperparathyroidism.
Thank you. I think the